Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition, Chapter 8, Therapeutic Relationships. Psychiatric mental health nursing is in many ways based on principles of science. A background in anatomy, physiology, and chemistry is the basis for providing safe and effective biological treatments. Knowledge of pharmacology, a medication's mechanism of action, indications for use, and adverse effects based on evidence-based studies and trials, is vital to nursing practice. However, it is the caring relationship and the development of the interpersonal skills needed to enhance and maintain such a relationship that make up the art of psychiatric nursing. A therapeutic relationship creates a space where caring and healing can occur. Concepts of the nurse-patient relationship. The healthcare community accepts the concept of patient-centered care as the gold standard. The core concepts of patient and family-centered care consist of 1. Dignity and respect, 2. Information sharing, 3. Patient and family participation, and 4. Collaboration in policy and program development. These tenets are familiar to members of the nursing profession as the nurse-patient relationship. The nurse-patient relationship is the basis of all psychiatric mental health nursing treatment approaches, regardless of the specific goals. The very first connections between nurse and patient are to establish an understanding that the nurse is safe, confidential, reliable, and consistent, and that the relationship will occur within appropriate and clear boundaries. Virtually all psychiatric disorders, including schizophrenia, bipolar disorder, and major depression, have biochemical and genetic components. However, many accompanying emotional problems, such as poor self-image, low self-esteem, and difficulties with adherence to a treatment regimen, can be significantly improved through a therapeutic nurse-patient relationship. All too often, patients entering treatment have taxed or exhausted their familial and social resources and find themselves isolated and in need of emotional support. We all have distinct gifts, unique personality traits, and talents that we can learn to use creatively to form positive bonds with others. The use of these gifts to promote healing in others is referred to as the therapeutic use of self. A positive therapeutic alliance, which is collaborative and respectful, is one of the best predictors of positive outcomes in therapy. Importance of talk therapy. A formalized approach to talk therapy that is based on theoretical models is called psychotherapy. Healthcare providers with advanced degrees and specialized knowledge, including psychiatric mental health advanced practice registered nurses, psychiatrists, and psychologists, are licensed to practice psychotherapy. Evidence suggests that psychotherapy within a therapeutic partnership actually changes brain chemistry in much the same way as medication. Thus, the best treatment for most psychiatric problems, less so with psychotic disorders, is a combination of medication and psychotherapy. Basic level psychiatric mental health nurses do not practice psychotherapy as this is an advanced skill. They do, however, use counseling techniques in the context of the therapeutic relationship. Counseling is a supportive, face-to-face process that helps individuals problem solve, resolve personal conflicts, and feel supported. Goals and functions. The nurse-patient relationship is often loosely defined, but a therapeutic nurse-patient relationship has specific goals and functions, including the following: facilitating communication of distressing thoughts and feelings, assisting patients with problem solving to help facilitate activities of daily living, helping patients examine self-defeating behaviors and test alternatives, promoting self-care and independence, providing education about medications and symptom management, promoting recovery. Social versus therapeutic. A relationship is an interpersonal process that involves two or more people. Throughout life, we meet people in a variety of settings and share an array of experiences. With some individuals, we develop long-term relationships. With others, the relationship lasts only a short time. Naturally, the kinds of relationships we enter vary from person to person and from situation to situation. Generally, relationships are intimate, social, or therapeutic. Intimate relationships occur between people who have an emotional commitment to each other. Within intimate relationships, mutual needs are met and intimate desires and hopes are shared. Morally, legally, and ethically, nurses and nursing students do not have intimate relationships with patients. Therefore, for the purpose of this chapter, we will limit our exploration to clarifying the differences between social and therapeutic relationships. A social relationship is primarily initiated for the purposes of friendship, socialization, enjoyment, or accomplishment of a task. Mutual needs are met during social interaction, e.g., participants share ideas, feelings, and experiences. Communication skills may include giving advice and sometimes meeting basic dependency needs, such as lending money and helping with jobs. Often, the content of the communication is superficial. During social interactions, roles may shift, such as being the listener one day and being listened to the next. Within a social relationship, there is little emphasis on the evaluation of the interaction. In the following example, notice the casual, friend-like tone of the nurse. Patient: "Oh, I just hate to be alone. It's getting me down, and sometimes it hurts so much." Nurse: "I know how you feel. I don't like being alone either. What I do is get on Facebook and see if anyone wants to do something. Maybe you should try this." In this response, the nurse is minimizing the patient's feelings and giving advice prematurely. Patient: "I don't get on Facebook. Anyway, I usually don't even feel like going out. I just sit at home feeling lonely and empty." Nurse: "Most of us feel like that at one time or another. Maybe if you took a class or joined a group, you could meet more people. I know of some great groups you could join." Again, the nurse is not hearing the patient's distress and is minimizing her pain and isolation. The nurse goes on to give the patient unwanted and unhelpful advice, thus closing off the patient's feelings and experience. In a therapeutic relationship, the nurse maximizes communication skills, understanding of human behaviors, and personal strengths to enhance the patient's growth. Patients more easily engage in the relationship when the clinician's interactions address their concerns, respect patients as partners in decision-making, and use straightforward language. These interactions are evidence that the focus of the relationship is on the patient's ideas, experience, and feelings. Inherent in a therapeutic relationship is the nurse's addressing issues introduced by the patient during the initial nursing assessment or in subsequent meetings. The nurse and the patient identify areas that need exploration and periodically evaluate the degree of progress of the patient. Although the nurse may assume a variety of roles, e.g., teacher, counselor, socializing agent, liaison, the relationship is consistently focused on the patient's problems and needs. Nurses' needs are met outside the relationship. Nurses who want the patient to like me, do as I suggest, or give me recognition undercut the needs of the patient. Nursing students have the opportunity to develop a therapeutic relationship with patients while having the support of both clinical faculty and nursing staff. This clinical supervision is a mentoring relationship characterized by feedback and evaluation. Typically, students experience a gradual increase in autonomy and responsibility. Communication skills and knowledge of the stages and phenomena in a therapeutic relationship are crucial tools in the formation and maintenance of that relationship. Within the context of a therapeutic relationship, the nurse will identify the needs of the patient and explore them, establish clear boundaries, encourage alternate problem-solving approaches, help the patient develop new coping skills, support behavioral change. Just like staff nurses, nursing students may struggle with the boundaries between social and therapeutic relationships because there is a fine line between the two. In fact, students often feel more comfortable being a friend because it is a more familiar role, especially with patients close to their own age. When this occurs, the student needs to make it clear to themselves and the patient that the relationship is a therapeutic one. This does not mean that the nurse is not friendly towards the patient, and it does not mean that talking about everyday topics, e.g. television, weather, and children's pictures is forbidden. In fact, a small amount of self-disclosure on the nurse's part may strengthen the therapeutic relationship. For example, your patient is about 24 years old, your age, and asks you about nursing school and what the hardest parts are. Briefly sharing your views on nursing school will increase the trust in the relationship. Can you imagine saying, "We won't be talking about me"? On the other hand, multiple questions about your dating life by a sexually preoccupied patient should result in redirection and clarification of roles. In a therapeutic relationship, the patient's problems and concerns are explored. Both patient and nurse discuss potential solutions. The patient, as in the following example, implements the solutions. Patient: "Oh, I just hate to be alone. It's getting me down, and sometimes it hurts so much." Nurse: "Loneliness can be painful. What is going on now that you are feeling so alone?" Patient: "Well, my mom died 2 years ago, and last month, oh, I am so scared." Patient takes a deep breath, looks down, and looks as if she might cry. Nurse sits in silence while the patient recovers. Go on. Patient: "My boyfriend left for Afghanistan. I haven't heard from him, and they say he's missing. He was my best friend, and we are going to get married. If he dies, I don't want to live." Nurse leans in slightly, nodding gently. That must be scary, not knowing what is going on with your boyfriend. Have you thought of killing yourself? Patient: "Well, if he dies, I will. I can't live without him." Nurse: "Have you ever felt like this before?" Patient: "Yes, when my mom died. I was depressed for about a year until I met my boyfriend." Nurse: "It sounds as if you're going through a very painful and scary time. Perhaps you and I can talk some more and come up with some ways for you to feel less anxious, scared, and overwhelmed. Would you be willing to work on this together?" Sometimes the relationship may be informal and not extensive, such as when the nurse and patient meet for only a few sessions. Even though it is brief, the relationship may be substantial, useful, and important for the patient. This limited relationship is referred to as a therapeutic encounter. When the nurse shows genuine concern for another's circumstances, has positive regard and empathy, even a short encounter can have a powerful effect. At other times, the encounters may be longer and more formal, such as inpatient settings, community mental health centers, crisis centers, and freestanding psychiatric facilities. This longer time span allows the therapeutic nurse-patient relationship to be more fully developed. Relationship boundaries and roles. Establishing boundaries. Professional boundaries exist to protect patients. Boundaries are to be expected and accepted, social, physical, and psychological boundaries that separate nurses from patients. This separation is essential considering the power differential between the nurse and the patient. This differential also exists between you and the patient, even if you do not feel powerful. You have read the patient's chart, you are there to help, you are close to becoming a registered nurse, and you are not a patient. These qualities put nursing students in a position of some authority, particularly from the patient's perspective. Nurses and other healthcare workers should seek a level of involvement that is healthy. A well-defined therapeutic nurse-patient relationship allows the establishment of clear boundaries. These boundaries provide a safe space in which the patient can explore feelings and treatment concerns. Figure 8.1 illustrates the balance of involvement in a therapeutic relationship. Blurring of boundaries. Boundaries are always at risk for becoming blurred. Two common circumstances in which boundaries are blurred are 1. When the relationship slips into a social context, and 2. When the nurse's needs for attention, affection, and emotional support are met at the expense of the patient's needs. Boundaries are necessary to protect the patient. The most extreme boundary violations are those of a sexual nature. This type of violation results in high levels of malpractice actions and the loss of professional licensure on the part of the nurse. Consider the case of the 48-year-old psychiatric nurse who had, in his words, a loving and sexual relationship with a 19-year-old patient after she was discharged. The licensing board determined that his actions could have resulted in harm due to her clear vulnerability. The board also stated that the serious misconduct was abuse due to the special position of trust he held. The nurse lost his job and his license. Other boundary issues are not as obvious. Table 8.1 illustrates some examples of patient and nurse behaviors that reflect blurred boundaries. Blurring of roles. Blurring of roles in the nurse-patient relationship is often a result of unrecognized transference and countertransference. Transference. Sigmund Freud originally identified transference as a phenomenon when he used psychoanalysis to treat patients. Transference occurs when the patient unconsciously and inappropriately displaces or transfers onto the nurse feelings and behaviors related to significant figures in the patient's past. The patient may even say, "You remind me of my mother, sister, father, brother, etc." Patient: "Oh, you are so high and mighty. Did anyone ever tell you that you are a cold, unfeeling machine just like others I know?" Nurse: "Let's talk about a person who is or was cold and unfeeling towards you." In this example, the patient is experiencing the nurse in the same way she experienced significant others during her formative years. In this case, the patient's mother was aloof, leaving the patient with feelings of isolation, worthlessness, and anger. Although transference occurs in all relationships, it seems to be intensified in relationships where one person is an authority. This may occur because parental figures were the original figures of authority. Nurses, physicians, and social workers all are potential objects of transference. This transference may be positive or negative. If a patient is motivated to work with you, completes assignments between sessions, and shares feelings openly, it is likely the patient is experiencing positive transference. Positive transference does not need to be addressed with the patient. However, the nurse may need to explore negative transference that threatens the nurse-patient relationship. Common forms of transference include the desire for affection or respect and the gratification of dependency needs. Other transferential feelings are hostility, jealousy, competitiveness, and love. Sometimes patients experience positive or negative thoughts, feelings, and reactions that are realistic and appropriate and not a result of transference onto the healthcare worker. For example, if a nurse makes promises to the patient that are not kept, such as not showing up for a meeting, the patient may feel resentment and mistrust towards the nurse. Countertransference is transference in reverse. It occurs when the nurse unconsciously displaces feelings related to significant figures in the nurse's past onto the patient. Frequently, the intense emotions of transference on the part of the patient bring out countertransference in the nurse. For example, you remind your patient of his much-loved older sister, and he works very hard to please you. In response to this idealization and caring, you experience feelings of tenderness toward the patient and spend extra time with him each day. Countertransference often results in over-involvement and impairs the therapeutic relationship. Patients are experienced not as individuals, but rather as extensions of ourselves. Example: patient: "Well, I decided not to go to that dumb group. Hi, I'm so-and-so, and I'm an alcoholic. Who cares?" Patient sits slumped in a chair chewing gum and nonchalantly looking around. Nurse, in an impassioned tone: "You seem to always sabotage your chances. You need AA to get in control of your life. Last week you were going to go, and now you've disappointed everyone." In this case, the patient reminds the nurse of her mother, who was an alcoholic. The nurse took it as a personal failure that her mother never sought recovery. The nurse sorts her feelings and realizes the feelings of disappointment and failure belonged with her mother and not the patient. She starts out the next session with the following approach. Nurse: "Look, I was thinking about yesterday, and I realized the decision to go to AA or find other help is solely up to you. Let's talk about what happened to change your mind about going to the meeting." If the nurse feels either a strongly positive or a strongly negative reaction to a patient, the feeling most often signals countertransference. One common sign is over-identification with the patient. In this situation, the nurse may have difficulty recognizing or objectively seeing patient problems that are similar to the nurse's own. For example, a nurse who is struggling with a depressed family member may feel disinterested, cold, or disgusted toward a depressed patient. Other indicators of countertransference are when the nurse gets involved in power struggles, competition, or arguments with the patient. Table 8.2 lists some common countertransference reactions. That's a big table. It takes up almost the entire page. We can look at that later. Identifying and working through transference and countertransference issues is crucial in accomplishing professional growth and in helping the patient meet his or her goals. No matter how hard clinicians try to examine the responses objectively, professional support and help are extremely helpful. Supervision by peers or by the therapeutic team can help work through transference and countertransference, as well as numerous other issues. Regularly scheduled supervision sessions provide the nurse with the opportunity to increase self-awareness, clinical skills, and growth, as well as allow for continued growth of the patient. Self-check on boundaries. It is useful for all of us to take time out to be reflective and aware of our thoughts and actions with patients, as well as with colleagues, friends, and family. Figure 8.2 is a helpful boundary self-test you can use throughout your career, no matter what the area of nursing you choose. A focus on self-awareness. While nurses routinely perform clinical assessments on patients, they are not usually trained to know and understand themselves. In psychiatric nursing, self-awareness is a key component to forming a therapeutic relationship. We all have likes, e.g. sweets or salty foods, and areas of interest, e.g. sports and reality shows. We're usually aware of those aspects of our personality, and it is fairly simple not to let a difference in what we like interfere with our ability to provide care. More sacred to us than likes or dislikes are our values and beliefs. These two concepts provide us with a way to conduct ourselves and give life meaning. It is easy to become threatened by others who possess different values and beliefs. It is important to develop awareness and acknowledge, then monitor our responses to patients who possess different values and beliefs. Values are abstract standards and represent an ideal, either positive or negative. It is your judgment of what is important in life. Examples of values are self-reliance, honesty, cleanliness, organization, justice, respect, and a healthy lifestyle. You could probably list those things that you will find most personally important and valuable. Beliefs are another area of self-awareness. They are defined in several different ways. Each of the definitions has relevance to the practice of psychiatric nursing and the therapeutic relationship. 1. An opinion or conviction, something that you hold to be true. For example, healthcare is a right for everyone, just like having paved roads. This type of belief may be rational, the earth is round, or irrational or delusional, my brain is being monitored. 2. Confidence, trust, or faith. For example, I believe that my doctor is the best in her field. 3. Religious tenets, creed, or faith. For example, it's fine if you celebrate birthdays, but in my religion, we don't. When working with patients, it is important for nurses to understand that our values and beliefs are not necessarily right, and certainly not right for everyone. It is helpful to realize that our values and beliefs, 1. Reflect our own culture or subculture, 2. Are derived from a range of choices, and 3. Are those we have chosen for ourselves, from a variety of influences and role models. These chosen values stem from religious, cultural, and societal factors. Our values guide us in making decisions and taking actions that we hope will make our lives meaningful, rewarding, and fulfilled. Working with others whose values and beliefs are radically different from our own can be a challenge. Topics that cause controversy in society in general, including religion, gender roles, abortion, war, politics, money, drugs, alcohol, sex, and corporal punishment, also can cause conflict between nurses and patients. What happens when the nurse's values and beliefs are very different from those of a patient? Consider the following examples of possible conflicts. The patient is planning to have an abortion, which is against the nurse's belief that life begins at conception. The nurse values cleanliness while the patient believes that showering more than once a week wastes water and harms the environment. The nurse believes in feminism and values women's rights. She resents her female patient who wears a hijab, head covering, for religious reasons. The patient makes disparaging remarks and uses insulting language about a certain race of people. The nurse has a strong religious belief system and thinks that everyone needs the support of a church, whereas the patient does not believe in organized religion. Self-awareness requires that we understand what we value and those beliefs that guide our behavior. Being self-aware helps us to accept the uniqueness and difference in others. Peplow's model of the nurse-patient relationship. Hildegard Peplow introduced the concept of the nurse-patient relationship in 1952 in her groundbreaking book, Interpersonal Relations in Nursing. This model of the nurse-patient relationship is well accepted in the United States and Canada as an important tool for all nursing practice. A professional nurse-patient relationship consists of a nurse who has skills and expertise and a patient who wants to alleviate suffering, find solutions to problems, explore different avenues to increase quality of life, or find an advocate. Peplow, 1952, proposed that the nurse-patient relationship facilitates forward movement for both the nurse and the patient. The interactive nurse-patient process is designed to facilitate the patient's boundary management, independent problem-solving, and decision-making that promotes autonomy. Peplow, 1952-1999, described the nurse-patient relationship as evolving through three distinct interlocking and overlapping phases: an additional pre-orientation phase, during which the nurse prepares for the orientation phase, is included. The four phases are as follows: 1. Pre-orientation phase, 2. Orientation phase, 3. Working phase, 4. Termination phase. Most likely you will not have the time to develop all phases of the nurse-patient relationship in your brief psychiatric mental health nursing rotation. However, it is important to be aware of these phases to recognize and use them later. Pre-orientation phase. The pre-orientation phase begins with preparing for your assignment. The chart is a rich source of information, including mental and physical evaluation, progress notes, and patient orders. You will probably be required to research your patient's condition, learn about prescribed medications, and understand laboratory results. Staff may be available to share more anecdotal information or provide you with tips on how to best interact with your patient. Another task before meeting your patient is recognizing your own thoughts and feelings regarding this first meeting. Nursing students usually have many concerns and experience anxiety on their first clinical day. These universal concerns include being afraid of persons with psychiatric problems or saying the wrong thing, and of not knowing what to do in response to certain patient behaviors. Table 8.3 identifies patient behaviors, e.g. crying, asking a nurse to keep a secret, threatening to commit suicide, giving a gift, or wanting physical contact, and gives examples of possible reactions and suggested responses. Experienced faculty and staff monitor the unit atmosphere and have a sixth sense for behaviors that indicate escalating tension. They are trained in crisis interventions, and formal security is often available on site to give the staff support. Your instructor will set the ground rules for safety during the first clinical day. These rules may include not going into a patient's room alone, staying where others are around in an open area, and reporting signs and symptoms of escalating anxiety. Orientation phase. The orientation phase can last a few meetings or extend over a longer period. It is the first time the nurse and the patient meet and is the phase in which the nurse conducts the initial interview. During the orientation phase, the patient may begin to express thoughts and feelings, identify problems, and discuss realistic goals. Specific tasks of the orientation phase follow. Introductions. The first task of the orientation phase is introductions. The patient needs to know about the nurse, who the nurse is and the nurse's background, and the purpose of the meetings. For example, a student might furnish the following information. Student: Hello, Mrs. Chang. I'm Bob Jacobs. I'm a registered nurse student from Fairlawn University. I am in my psychiatric rotation and will be coming here for the next 6 Thursdays. I would like to spend time with you on Thursdays until you are discharged. I'm here to be a support person for you as you work on your treatment goals. Knowing what the patient would like to be called is also essential. Names and titles are meaningful to most people, In the previous example, the student began by using a formal title of Miss Chang. After checking the patient's identification band and reading it out loud, Dorothy Chang asked, "What would you like to be called?" Establishing rapport. A major emphasis during the first few encounters with the patient is on providing an atmosphere in which trust and understanding or rapport can grow. As in any relationship, you can nurture rapport by demonstrating genuineness, empathy, and unconditional positive regard. Being consistent, offering assistance in problem solving, and providing support are also essential aspects of establishing and maintaining rapport. Specifying a contract. A contract emphasizes the patient's participation and responsibility because it shows that the nurse does something with the patient rather than for the patient. The contract, either stated or written, contains the place, time, date, and duration of the meetings. You should also discuss termination of the relationship. Student: Miss Chang, we will meet at 10 a.m. each Thursday in the consultation room. We have 45 minutes to discuss the feelings that you have identified. We will also discuss your diagnosis and symptom management and review your medications. Like I said earlier, we will be able to work together until you are discharged. Explaining confidentiality. The patient has a right to know, 1, who else will be given the information shared with the nurse, and 2, that the information may be shared with specific people, such as a clinical supervisor, the physician, the staff, or other students in conference. The patient also needs to know that the information will not be shared with relatives, friends, or others outside the treatment team, except in extreme situations. Extreme situations include child or elder abuse and threats of self-harm or harm to others. The nurse must be aware of the patient's right to confidentiality and must not violate that right. Safeguarding the privacy and confidentiality of patients is not only an ethical obligation, but a legal responsibility as well. Working phase. A strong working relationship allows the patient to safely experience increased levels of anxiety and recognize dysfunctional responses. New and more adaptive coping behaviors can be practiced within the context of the working phase. Specific tasks for the nurse in this phase include gathering further data, identifying problem-solving skills and self-esteem, providing education about the disorder, promoting symptom management, providing medication education, evaluating progress. During the working phase, the nurse and patient identify and explore areas that are causing problems in the patient's life. Often, the patient's coping methods were developed to survive in a chaotic and dysfunctional family environment. Although coping methods may have worked for the patient at an earlier age, they may now interfere with the patient's functioning and interpersonal relationships. An important aspect of this working relationship is patient education. In order to facilitate this education, you need to become familiar with biological factors, e.g., genetic, biochemical, and also with psychological factors, e.g., cognitive distortions, learned helplessness, that may be the basis of your patient's psychiatric disorders. Understanding psychotropic medication, laboratory work and results, and other treatments is also essential. This knowledge prepares you to help your patients to learn, which in turn prepares them to take an active role in their own care and eventual recovery. Termination phase. The termination phase is the final, integral phase of the nurse-patient relationship. You discuss termination during the first interview, and again during the working stage at appropriate times. Termination may occur when the patient is discharged or when the student's clinical rotation ends. Basically, the tasks of termination include the following: summarizing the goals and objective achieved in the relationship, discussing ways for the patient to incorporate into daily life any new coping strategies learned, reviewing situations that occurred during the nurse-patient relationship, exchanging memories, which can help validate the experience for both nurse and patient and facilitate closure of that relationship. Termination often awakens strong feelings in both the nurse and patient. Termination of the relationship signifies a loss for both, although the intensity and meaning of termination may be different for each. If a patient has unresolved feelings of abandonment, loneliness, or rejection, these feelings may be reawakened during the termination process. This process can be an opportunity for the patient to express these feelings, perhaps for the first time. If a nurse has been working with a patient for a while, It is important for the nurse to recognize that separation may be difficult for the patient. A general question such as, "How do you feel about being discharged?" may provide the opening necessary for the patient to describe feelings. Part of the termination process is to discuss the patient's plans for the future. If the termination is the result of a discharge, part of these plans have usually been discussed by the psychiatrist or advanced practice nurse, including follow-up care and referrals. Registered nurses generally reinforce those plans and emphasize understanding of medications and recognizing when symptoms are getting out of control. Self-help groups can also be encouraged. Factors that promote patients' growth. Rogers and Truax, 1967, identified 3 personal characteristics of the nurse that help promote change and growth in patients. Factors still valued today as vital components of establishing a therapeutic relationship. 1. Genuineness. 2. Empathy. And 3. Positive regard. These are some of the intangibles that are at the heart of the art of nursing and patient-centered care. Genuineness refers to a nurse's ability to be open, honest, and authentic in interactions with patients. Being genuine is a key ingredient in building trust. When a person is genuine, one gets the sense that what is displayed on the outside of the person is congruent with who the person is on the inside. Nurses convey genuineness by listening to and communicating clearly with patients. Being genuine in a therapeutic relationship implies the ability to use therapeutic communication tools in an appropriately spontaneous manner rather than rigidly or in a parrot-like fashion. Empathy. Empathy occurs when the healing person attempts to understand the world from the patient's perspective. Essentially, it means temporarily living in the other's life, moving about it delicately without making judgments. Ward and colleagues, 2012, state that empathy is consistent with improved patient outcomes and increased patient satisfaction with care. However, it does not seem that we are doing a great job of instilling empathy in nursing students. In a study of 214 undergraduate nursing students, empathy actually declined over the course of a year in which students were practicing in the clinical years. These findings are consistent with those of medical students as they progress through years of school. It may be that once empathetic students are following the cue of other nurses. What do you think would cause students to demonstrate less empathy? Researchers have wondered whether empathy can be taught. Chaffin, 2010, demonstrated that simulation exercises might help students increase their range and depth of understanding another's experience. Students were asked to listen to a CD with headphones that simulated the voices heard by a person with schizophrenia. These distracting voices were present while their lab partners were performing a mental status exam on them. During this exam, students were annoyed, distracted, frustrated, angry, and overwhelmed. Students who were subjected to this experiment seemed to empathize more with psychotic patients. After this experience, students were choosing to interact with more patients on a one-to-one basis, more willing to wait for patients to answer, desiring a therapeutic relationship with patients, more understanding, focused, and caring. Can the use of clinical simulation provide more depth in understanding and a more lasting impression of patient experience? From the study and others, the answer seems to be yes. Empathy versus sympathy. You may wonder how empathy differs from sympathy. A simple way to distinguish them is that in empathy, we understand the feelings of others, and in sympathy, we feel pity or sorrow for others. Although these are considered nurturing human traits, they may not be particularly useful in a therapeutic relationship. The following examples clarify the distinction between empathy and sympathy. A friend tells you that her mother was just diagnosed with inoperable cancer. Your friend then begins to cry and pound the table with her fist. Sympathetic response: I feel so bad for you, tearing up. I know how close you are to your mom. She's such an amazing person. Oh, I'm so sorry. You hug your friend. Empathetic response: this must be devastating for you. Silence. It must seem so unfair. What thoughts and feelings are you having? You stay with the patient and listen. Empathy is not a technique, but rather an attitude that conveys respect, acceptance, and validation of the patient's strength. Empathy may be one of the most important qualities that a psychiatric mental health nurse can possess. Positive regard. Positive regard implies respect. It is the ability to view another person as being worthy of caring about and as someone who has strengths and achievement potential. Positive regard is usually communicated indirectly by attitudes and actions rather than directly by words. Attitudes. One attitude that might convey positive regard or respect is willingness to work with the patient. That is, the nurse takes the patient and the relationship seriously. The experience is viewed not as a job or a part of a course, but as an opportunity to work with patients to help them develop personal resources and actualize more of their potential in living. Actions. Some actions that manifest an attitude of respect are attending, suspending value judgments, and helping patients develop their own resources. Attending. Attending behavior is the foundation of a therapeutic relationship. To succeed, nurses must pay attention to their patients in culturally and individually appropriate ways. Attending is a special kind of listening that refers to an intensity of presence or being with the patient. At times, simply being with another person during a painful time can make a difference. Posture, eye contact, and body language are nonverbal behaviors that reflect the degree of attending and are highly culturally influenced. Refer to Chapter 9 for a more detailed discussion of the cultural implications of nonverbal communication. Suspending value judgments. As previously discussed, we all have values and beliefs. Using our own value systems to judge patients' thoughts, feelings, or behaviors is not helpful or productive. For example, if a patient is taking drugs or is involved in risky sexual behavior, the nurse recognizes that these behaviors are unhealthy. However, labeling these activities as bad or good is not useful. Rather, the nurse should help the patient explore the thoughts and feelings that influence this behavior. Judgment on the part of the nurse will most likely interfere with further exploration. The first steps in eliminating judgmental thinking and behaviors are to 1. Recognize their presence, 2. Identify how or where you learn these responses, and 3. Construct alternative ways to view the patient's thinking and behavior. Denying judgmental thinking will only compound the problem. Patient. I guess you could consider me an addictive personality. I love to gamble when I have money and spend most of the time in the casino. Seems like I'm hooking up with a different woman every time I'm there, and it always ends in sex. A judgmental response would be, Nurse A. So, your compulsive gambling and promiscuous sexual behaviors really haven't brought you much happiness, have they? You're running away from your problems and could end up with an STD and broke. A more helpful response would be, Nurse B. So, your sexual and gambling activities are part of the picture also. How do these activities impact your life? In this example, Nurse B focuses on the patient's behaviors and how they affect his life. Nurse B does not introduce personal value statements or prejudices regarding the promiscuous behaviors, as does Nurse A. Helping patients develop resources. It is important that patients remain as independent as possible to develop new resources for problem solving. The nurse does not do the work the patient should be doing unless it is absolutely necessary, and then only as a step towards helping them act on their own. The following are examples of helping the patient to develop independence. Patient, this medication makes my mouth dry. Could you get me something to drink? Nurse, there's juice in the refrigerator. I'll wait here for you until you get back. Or, I'll walk with you while you get some juice from the refrigerator. Patient, could you ask the doctor to let me have a pass for the weekend? Nurse, your doctor will be on the unit this afternoon. I'll let her know that you want to speak with her. Consistently encouraging patients to use their own resources helps minimize the patient's feelings of helplessness and dependency. It also validates their ability to bring about change. And that's it for Chapter 8.